and then Shemaine. So hopefully you'll be able to hear things, and it'd be really good if we could have a conversation at the end with a really interesting question and answer session. So do feel free, as Alex has asked, to put things in the question and answer section, and I will make sure that we try and answer those and hopefully bring people into the conversation as well later. I think that'll be important. So let me share, and hopefully you'll be able to follow me through this and see what I'm seeing. Okay, so just before I start, I want to just point out that we're part of a big team at Keele. Often when you present something, it looks like there's just one or two individuals involved, but this is very much a project with a big team behind it. You can see those from Keele involved, our data managers, our statisticians. We've got a great team, and we're also being supported by the Keele Clinical Trials Unit, and a big thanks to our Impact Accelerator Unit for their support as well at Keele. And at the moment, we've also got help from the Health Innovation West Midlands team, and that's Chris Clues and Camwell Umar helping us. And they're helping with onboarding services that are coming on board with the database. And they're also doing that. Camwell at the moment is in the process of setting us up on a NHS Futures website, which is fantastic support. So thank you to them for what they do. So I'm going to start by just outlining what we see as the problem that we're trying to address with these databases. Obviously, our focus here is on musculoskeletal problems. I'll say MSK for short throughout the talk, but we're talking about back pain, knee pain, shoulder pain, all those very common conditions. It always, surprises me just how many people are affected. We think it's around a third of the UK population, around 20 million people living with MSK conditions, and they make up around 1 in 7 GP appointments, which is millions of visits each year. And they also contribute to thousands of visits to community MSK services, which is the bit we'll particularly be talking about today. Now, Versus Arthritis are a fabulous charity in the UK that many of us are part of and hugely support. Each year they publish a document called The State of Musculoskeletal Health, which is looking at UK-wide statistics for MSK conditions. And in section 3 of that report, they tend to look at provision of care. And interestingly, it's quite a short section. It's probably one of the shorter ones in the document. It's just 2 pages. I've put them here, and they talk about access to care to 2 things: to orthopedics, to joint and in terms of hip and knee replacements, joint replacements, and they also look at access to rheumatology services for people with inflammatory or suspected inflammatory MSK problems. What's our sort of thought as a team is that roughly is around 500,000 people that are covered by those statistics. But what we know is that there's around 10 million people a year seen for an MSK problem in primary care, and somewhere around 3 to 4 million people seeing community services each year. But sadly, there's no data on what's happening in all of those appointments and those visits. And as a result, there isn't anything in the Versus Arthritis annual report on that. We've also got a situation where patients are telling us that access to care and the quality of care that they're getting is getting worse. I don't know about you, but I'm also hearing that the morale and the sort of well-being among our clinicians, it's not only affecting a problem for GPs, but it's currently a growing problem among the MSK physiotherapy workforce. Mainly what we're hearing is that it's clinicians feeling that the patients are more and more complex, and that that is very overwhelming and hard to manage. And I guess that this is the problem that as an MSK research group, we're trying to solve. We're trying to provide the data that is currently missing around what's happening. The sort of data we have got from our research projects to date tells us that the treatment people are getting depends on which GP they see, where they live, and many people are getting care that we know doesn't work terribly well and is not recommended by NICE. In most areas, there's a significant group of MSK patients who are getting locked into having to keep going back to see their GP again and again. And we can also see that a lot of people are getting harmful medicines such as opioids, strong opioids, for the long term. And we can see that distressed and complex patients are often not getting the right support. And I guess what's frustrating is that so many of our NHS leaders and our GPs don't know how often that's happening in their area, and that can lead them to feeling a little powerless. It's really hard to know what to change when you're not measuring anything. And we call it the data invisibility problem, and you've probably heard about that. So here's a map that is I've shown this because this has come from the Midas research team. Actually, Ross Wilkie and colleagues at Keele have produced these maps, and they're heat maps that show the first one in the left in blue is showing the prevalence of chronic pain across the Staffordshire area. And if you look in sort of this area where we've got more pink and red, that's actually where the city of Stoke-on-Trent is, and it's where the areas of higher deprivation are. And we can see that that's obviously, and it's where the communities are shouldering the burden of chronic pain, and it's clearly much higher in certain areas. The map on the right in the grey is showing the prevalence of chronic pain and estimates for that across England. And the obvious reflection when you look at that kind of data and you think about managing MSK conditions is not all GP practices or community services or hospital services have the same situation on their hands. The context of the communities that they serve, such as the prevalence of pain and chronic pain in the community, is hugely important, and it varies substantially. Now, our team's vision is about helping to plug the data gap. We want to know what's happening to MSK patients. The big picture is we want to know what's happening across primary, community, and specialist hospital services, so that we could develop a learning health system, and it's a musculoskeletal learning health system that our focus is on. In other areas like cancer, we know that that has made a huge difference to the quality of care that's provided when you have data across the whole pathway. And at the moment, as I've said, for MSK conditions, we can see a little bit about what's going on in the hospital settings, but we can't really see what's happening in our community and our primary care settings. That's where the current data gap is. Now, a learning health system is a health system that is set up, it's designed to continuously improve itself using data and experience from everyday routine care. So what I like about it is rather than research and practice being quite separate with a big gap, a learning health system is trying to use research and analytics based on routine patient data to translate that into health intelligence and into insights that can change and improve care in the real time. So that's what we're really focused on doing as a team. I guess you might say to me, well, how's that different, Jonathan, from a quality improvement cycle or an audit? And you're right, it would have a lot of overlap, but I guess the vision that we've got is bigger. It's a quality improvement cycle is usually specific to a particular hospital, a particular service. Its audit data is often not considered research, and it often isn't research. Whereas a learning health system and what we're trying to do definitely is. We're definitely getting ethics. And this is about large-scale digital data that's across multiple services and multiple settings. So the vision is much bigger than perhaps just a quality improvement program. And we also want it to be self-sustaining. We want to have something that isn't just a short-term project, which when people move on, disappears. And something that's important to us as a team is that this learning health system is really aligned to strategy, that we look at where the policy is. And I've got here the 10-year health plan, the improvement framework, from NHS England, and also the major conditions strategy, just examples of the sort of policies that we're reading and saying we've got to make sure that we are designing this such that it aligns to the strategy nationally. So I'm just going to talk for a few minutes about Midas, which is where we've got some GP data, primary care data, and the dashboard that we've got for that. It's been a huge team of people, as you can see from the slide. It's a 5-year program that's just coming to the end at the end of September, and it's been really exciting program to be part of, where we're thinking about joining up data, data linkage across different settings, population settings, community settings, primary care settings. And one of the projects that I was leading was around the general practice cohort, where we went into 30 GP practices in the North Staffordshire, Stoke-on-Trent area. And we've got 2 cohorts from those 30 GP practices. We've got just over 2,000 adults who have given us survey data, telling us things like their pain intensity, their function, quality of life, all of that. And we've got that at baseline 3 months and 6 months. And they've given permission for us to have their electronic health record linked as well. We've also got a second cohort, which is much bigger, where the GP practices have allowed us to have 7 years of anonymized electronic health record data for patients with musculoskeletal problems. And that's given us 184,000 individuals who have had over 370,000 MSK consultations in those 30 GP practices. And it's just a huge data set. It's been really exciting for our team to start to look at, well, what's going on? What kind of care is being delivered out there? And we've sort of had this process of trying to define our data dictionaries, to define SNOMED codes, so that we can do all of that and start to describe what's happening. And there's actually a huge team of people. I won't go through them all, but you can see a big list of different people involved in looking at the Midas GP data and doing different sorts of analyses with that data set. And it's only fairly recent that we've had all of that data set and started to do this. But it's exciting that there's a big team looking at that. But what I wanted to show you was where we've got to with our prototype Midas GP dashboard. So one of my PhD students, Alex Braybrook, his work has been around quality indicators, but also trying to turn that huge data set into a dashboard. And we've been working with a great company called Viewit, who are a sort of data visualization expert team. And I'm going to show you where we've got to in the last few minutes that are my section before I hand over at about 20 minutes past 12 to the next talk. So I'm just going to switch over for a second to the data dashboard. So hopefully you can see that. I'm going to put it full screen. So what we've got here is a view of our 30 GP practices. You can see there's some of them are green, some of them are in the yellow, and some of them in the red. And the particular indicator I'm showing at the moment is the percentage who have been prescribed a fit note. So the mean is around 14% of patients are getting a fit note. And these are what we've done is we've pulled data on what we call the Keele MSK 500 SNOMED code list. So this is a range of MSK conditions, but I've restricted this to the non-inflammatory MSK conditions, and that's it's a lot of different codes. We think that our MSK 500 code list picks up the top 95% of MSK conditions. So there's not every MSK condition here, but it's certainly the majority. And if you have too big a tail, when you run your data extraction, you end up crashing the GP practice systems that you're trying to extract the data from. But what you've got here is a range of different GP practices in terms of, let's say, fit note prescribing. So this practice on the left here, practice 17, is giving 7.5% of their MSK patients a fit note, and this practice right up here is up at 19% of their MSK patients. And we know that that reflects a lot to do with the population that they serve, but also there are huge differences between GP practices in terms of their culture and their practice and how they operate. Down here is the sort of trend that you can see right from 2018 through to 2023, and you can see what's happening over the years in terms of fit note. And it's roughly stayed about the same, 14%. It's been down during COVID, it's been back up again, come down again. So we can see that fit notes haven't hugely changed over that time period. But if I look by different deprivation, so rather than looking at all the different 10 deprivation groups on the index of multiple deprivation, I'm just going to show you what happens if I just select the most deprived quintile, which is the two here from patients from the most deprived backgrounds. And you can see that their fit note rate is now sort of up at 19%, and how that has gone over the trend analysis over time. And let's compare that to the patients from the least deprived areas. So I'm going to turn that through to the most, these would be the sort of wealthiest patients, I guess. And you can see that now this is the mean here is down to 7.9%. And I guess if I take off and only look at the very wealthy ones, you're going to see it drops even further, but the numbers are smaller. Well, what's nice is you get to start to interact with the data, see what's happening, and see how some of the filters, we've got things like BMI, we've got deprivation, we've got age, we've got index body site. So if I put this back to all the different patients, but we could start to have a look at, let's look at just back pain for a second. So are we seeing, well, actually, we don't need to for this, because let me just look down here on the right. We can see fit note by different body sites here, stratified by different areas. So back pain is clearly the area that's getting fit notes the highest. And then you can see across age groups, which age groups are getting fit notes as well. So it's really interactive. It's quite useful. I'm just going to run through a few of the other indicators. This is the proportion of people who are getting long-term opioids. So from some GP practices where it's as low as 6%, up to others where it's as high as 17%. And what I didn't say is in the trend analysis, depending on which practice I click on. So if I click on 6%, so here's the mean there, around 10% of people. And this is that particular practice, which is really low in its prescribing of long-term opioids. Whereas this practice here, if I go to the one, practice 16, you can see they're much, much higher, and they have been higher over the whole 7-year period that we've been monitoring things. And it's by age category, they are higher than the mean for every age category. So this is just allowing us to sort of see what's going on across different GP practices. And there's a real picture that emerges when you start to play with the filters as to what's happening, what's changing over time, and what we're seeing. So opioid use is actually fairly steady as a mean across our practices over the time. Physiotherapy referrals, what's happening to that? Well, it dipped quite a bit from around 25% of people with an MSK condition being referred down to 18%. And then, as you can see, ever since COVID, it's just gone up and up and up. And that is something that the MSK services are having to cope with. Partly it's because they're being discouraged from orthopedic referrals. So if we look at orthopedics in our area, orthopedic referral has been falling, but it wasn't that high, around 3%. This particular GP practice here has been lower than the mean. Which practice is that? That's practice 16. And you can see that they're low across every age group and across every condition except for thoracic spines, which they are a little bit above for who they're sending to orthopedics. Now, imaging, what's happening to imaging in our GP practices? Well, that is going up. Again, it had a dip down in COVID, but the imaging is back on the rise and is above what it used to be. And some practices, it's clearly much higher than others. And the last thing I'll just show you is frequent attenders. And here what you can see is that the proportion of people, so frequent attenders we define as 6 or more times a year. Actually, because we do it in 6-month blocks, then it's 3 or more appointments in a 6-month period. But the frequent attenders, if anything, are falling, which is a surprise. There's a big proportion in some practices who are frequent attenders, right up at sort of 19-20% of their MSK patients. And what you tend to find is that there's a correlation where there's long-term opioids and things like amitriptyline, duloxetine being prescribed, then you get a lot more frequent attenders for MSK problems. Whereas other practices tend to do far less of that and are more proactive around referral to social prescribing, physiotherapy, community services. It also depends on how far away those physiotherapy services are from the GP practice. And we've got a number of other pages. I won't be able to go through them all, but for example, this one here is looking at consultation trends. And you can see that back in 2018, around 14% of people in a practice, adults, were coming in. That dipped right down in our GP practices, and then it's gone back up a little bit. It's recovered to just under 12%. And what we're seeing is that there are a few practices where it's recovered, and there are definitely practices down at this end where consultation rates are lower. Access to it for an MSK appointment is harder, and they haven't really gone back up as high as you might expect. This one has, interestingly. Some of them have and some haven't in terms of their recovery across different GP practices. So it's exciting for us to start to build the dashboards. We've got monthly meetings with commissioners, patients, and GPs, and they're starting to give us really helpful feedback. The View-It team are then going ahead, taking the feedback that we've got and iteratively improving the dashboard. And we've got about another month to work on this before our funding runs out. And what we've done as a team is we've applied for future funding to see if we could take this across our whole region. Use just under 400 GP practices. Are all part of our GraphNet shared care record. The data is there. We need to get ethical approval to use that in a dashboard like this, but we feel that that's a really important next step for us. And one of the things that we're excited about is we're building cost dashboards and carbon dashboards so that we can see what's happening in terms of carbon footprint and the variation across different areas, and we can see that that's quite substantial. And we can start to see what does good look like across our region, and where should we set the benchmarks, and how do we start to support GP practices who are struggling in certain areas to improve what they're doing for their MSK patients. So I'm going to stop there because we would like to talk mostly today about what's happening in our community data set. And I'm going to hand over to Roanna, who's going to tell you about the NHS side of that. So Roanna, over to you.
Sorry, just realised I hadn't put my mic on before I shared my screen. There we go. Hopefully everyone can see that. Okay, so hi everyone, my name's Roanna Burgess, and I'm the lead for the NHS side of the community data that we're going to talk to you about today. So just really leading on from Jonathan's talk. So this project's called the National MSK Audit and Research Database, but as we've heard, it's much more than an audit, and certainly we're working towards that learning health system approach. So what is it that we're trying to do? So this is a project that's evolved over the last couple of years, and the aim is still the same. Our aim is very much to try and fill that black hole that we've talked about in terms of scarcity of MSK community data. And what we're looking to do is really enable routinely collected MSK data from multiple providers of community services across the UK to be standardised. So for us all to be aligned and start to do it in the same way, and for us to then be able to share this data collectively across, as I say, multiple services. And for us as a research team to securely and safely store it, which obviously needs, for this kind of size of data, a specific place that's designed for storage of data to this size, so that we can then, as a research team, start to analyse it and produce this much needed large-scale MSK health intelligence. And with the aim of that then feeding this much wider learning health system approach. So our objectives really alongside that are, right from the start, is this feasible? So can we standardise? Can we align the way that services collect data? And is it feasible for that data to be shared at scale across the UK. And certainly we seem to have shown already that, yes, we are receiving now large amounts of data, and our next steps really start to look at the quality of that data and can we use it now to produce this meaningful health intelligence. Another aspect of this is key. We want to look at the variation. And at the moment, we're very much concentrating on the variation that we're seeing across those MSK services in terms of the population that they're treating. So very much similar to what Jonathan showed you in the GP data, where you've got huge differences in deprivation, huge differences then in complexity of patients right from that starting point. But then we will be moving on, and Shemaine will talk about this a little bit about this in her talk, how we then look at quality as part of that as well, and how we're improving patients as part of that episode of care. Another aspect of this is very much around the benchmarking. So again, demonstrated by those dashboards, that's the exact kind of information that we want to be delivering back to our community, so back to MSK services, so that they can use it as part of this learning health system approach to drive quality improvement in practice. So what data are we collecting? So again, a collection of different aspects of data. We have been focusing very much as we've started onboarding services on patient survey data. So that's outcomes and experiences. So it's something that many of us, and I lead an MSK service alongside my research role, we're all collecting outcomes and experience data. But to date, we've all been collecting slightly different things in slightly nuanced ways. So part of this project, we're really trying to get people to align that. So we're collecting the same outcomes, the same experiences, using the exact same questions, and that we're collecting at the same timescales. So this is at initial up to when they first come in to see a healthcare professional, and then again at 3 months after they first accessed an MSK service. Alongside that, we will then also look to collect consultations, so electronic health record data. We haven't got this data yet, but that's in the next step of the plan. And then we will specifically be looking at, again, some similar things to what we've looked at in the GP survey, the GP data that Jonathan showed us. So again, we'll be looking at things like investigations and imaging and referrals onwards, and starting to compare different practices across, as I say, multiple MSK services. And all of that data is then, as you can see with the arrows, is going to be fed into this West Midlands secure data environment. So at the moment, all of the data is coming to Keele, and then once it's been cleaned and checked, it's flowing then through, and we've just started flowing this data through into this West Midlands secure data environment. And the benefit of that environment is it's made for this exact solution, so to house big data, and also it's got that facility then for us to link to other NHS data sets within the secure data environment. So in terms of future potential, we've got that huge potential to then have data across the MSK pathway, which, as Jonathan alluded to, would be fantastic. Alongside that, we're also collecting some organisational data just to give it a little bit of context. So things like waiting times, appointment times, staffing, etc. And obviously that's changing a lot at the moment with different financial pressures. So again, it's really important for us to get context. And as you can see on the right side of this slide, we're then wanting to feed into these very specific dashboards. So again, the vision is that we'll bring all of this data together so that services can manipulate that data, just as Jonathan showed you, to see how they are sitting against their peers, etc. So how are we getting on with onboarding services? So we've got 55 MSK services, or I should say providers actually, 55 providers of MSK services across the UK that have registered interest. So we've had huge interest from the community, which has been fantastic. And then as I'm just going to go through, in terms of over the last year, how many we've got actually starting to submit data, we've got 5 providers of MSK services that are all the way through to submitting data, and that actually gives us 24 musculoskeletal services that we now have data represented in our database, which is fantastic. And actually within those 5 providers, we've actually got 28 services, but at the moment only 24 of those we've got data for. And as you can see, we've got this kind of concertina of services that are waiting then as part of that process to start their own submissions. This is just a slide that gives you just a little bit of a overview of the data that we're collecting, but again, we can give you links to this if you want to then have a look at that data in more detail. And just in a bit of a nutshell, really, in terms of the outcome experience data that we're collecting, it's probably things that you would expect. So it's things like complexity of the patients that are coming in. So what pain site, how long have they had their symptoms, have they had previous episodes? And a lot of these elements we're using to, at a later point, we'll be using to case mix adjust so that we can ensure that we are comparing services appropriately. We're also using the Musculoskeletal Health Questionnaire, which many of you will know is a 14-item questionnaire with one question on physical activity. We've actually, or Shemaine and her team, have actually worked really hard on reducing the MSKHQ into a 6-item survey, and we will release that later this year. So actually what I'm showing you in this slide is the minimised data set. So we've been working hard not only to release a standardised data set, but we want to minimise that as much as possible. And we've been learning from that over this last year. We're then collecting information on pain, on physical activity, and specifically on work, which is obviously another key area for MSK problems. And alongside that, very much on demographics and equity, so that we can start to look at inequalities that exist both at baseline, but also in terms of quality of care as well. At 3 months, again, we're collecting the same outcome measures as you'd expect, plus the global rating of change scale and a short MSK patient-reported experience measure as well, which again has been reduced from the original. And just to say, those bits in purple, which I'm not reading out, those are the additional things that's also collected in the private database as well, which I'll let Shemaine talk about later. This is also, just to give you a sense of it, a list of codes. So we're starting to collate these code lists that we can start to extract things like, as I say, investigations and onward referrals from the electronic health record data, very much learning from the methods from MIDAS, the project that Jonathan spoke about. And in the next few slides, I'm just going to give you a little bit on what we've done to date in terms of data analysis. So we've had a year really of collecting data, with services kind of getting on board in that time. We've now got over 90,000 patients that have consented for their data to be part of that database and that we've brought into the database, which is fantastic. And actually, that was up until the end of August. So now we're well into September. We're probably over 100,000 already. We just haven't updated that figure yet. In terms of services that are represented, these are the 24 services that we've got at the moment, and you can see that we've got good spread across England. We've got a few places that we need to kind of expand into, and certainly we want to go kind of wider than that, so we've got better spread across the UK, but it's a good start. And in terms of what our data is showing us, so I'm just going to give you, say, just a few snippets today because of time, but this is our main patient-reported outcome measure, the Musculoskeletal Health Questionnaire, which is a score from 0 to 56 with a lower score, meaning a lower level of MSK health. And you can see that across, this is the 20 services that were in our first 6 months of data. And there's about 50,000 patients that are part of this particular, as I say, analysis. And what you can see from here is obviously the lowest score for this service 16 is around 22. And that goes up to the highest score for service 2, which is around 28. So there is a bit of variability in terms of what level of symptoms patients are coming in at across these different services. And what's interesting, actually, when you look at the next 6 months of data, there's even more variation, but we haven't quite finished analysing that yet. Then just to show you again a little bit about deprivation. So what you can see in this slide is that the orange and pale blue, those are the lowest quintiles of deprivation. So those are the patients with the highest level of deprivation. So you can see that for example, service 16 and service 20 have around 75% of patients that are in the most deprived quintile of patients. So that's a very deprived population. And if you compare that to, for example, service 8, they've only got around 10% of patients that are in those lowest 2 quintiles in terms of deprivation. So it's quite different. And interestingly then, if I flip back to the MSKHQ, you can see that service 16 actually has the lowest MSK-HQ, so the most severe patients, as well as having the most deprived patients. And Service 8, which had the least deprived patients, has one of the highest starting scores for the MSK-HQ on average. So there's quite a difference, and you can see already that's starting to support what Jonathan showed in terms of the MIDAS data and the GP data. Into my next slide again, that's just something just to reflect again a little bit about work. So what we can see from this slide is of those patients that are in employment, around 30% of patients presenting across these services were taking time off work because of their MSK condition, and had taken time off work in that last 3 months. So that seems to be fairly consistent across services. But obviously what's not shown in this slide, possibly in services where you've got much higher level of deprivation, you may also have high levels of unemployment. So again, it needs to be looked at in context of some of those other factors as well. So I hope I've just given you a little bit of a taste of the types of data that we're looking at. And as I say, we're really excited. We're already getting stuck into that next 6 months of data. And obviously we want to start to look at all aspects of that and start to feed our quality indicators and our learning health system. But we're trying to take a step-by-step approach, but really with, as I say, the aim of providing that really useful, meaningful health intelligence to the wider MSK community. So thank you. And over to you, Shemaine.
Yeah. Can you unmute yourself, Shemaine?
Sorry, there we go. Okay, just going to share screen and press. Oh, sorry, but I haven't got it on play. Sorry. 1 moment, sorry. Okay, are we there? Can everyone see that first screen?
Yep, that's looking good.
Yeah. Oh, good. Okay, we got there in the end. Okay, so hi everyone. I'm Dr. Shemaine Murtagh, and I'm a Senior Research Fellow at Keele University, and I lead the Data for Impact project. So this is the data collection in private practice. So today I'll be talking about the data collection itself, and then I'll be moving on to talk about our developments of the quality framework that we're putting together for MSK Physiotherapy. Okay, so just to give you a quick insight into the presentation, we'll look at the data collection itself, look at the existing data collection, because it first began in 2014, and we're moving forward to a launch of a new data collection platform that's being launched next week. And then I'll provide you context and updates about our work on the development of the quality framework and how this, the Data for Impact project is collecting data that will enable this. Okay. So a little bit, you've heard about the MSK National Audit that Roanna and Jonathan have talked about, and this, the Data for Impact project for private practice directly aligns to the data set that's being collected in the NHS. And the two projects have an aligned kind of aims and outlook to understand patient outcomes and experiences, to benchmark quality across both the NHS and private practice, to inform best practice and service improvement, but also to highlight any health inequalities, to understand who is accessing care and what those outcomes are for various different subgroups. So focusing on the Data for Impact project. So this is an ongoing long project that's first developed in 2014. We initially, so at the moment we've got 120,000 data sets that have been collected across private practices with over 800 clinics that have registered that are collecting data. Our current data collection system was predominantly clinician-led. There was limited alignment and kind of integration with PMS system and no automated PROM and PREM system, although we did have PROMs integrated into the data collection and a standalone patient reported outcome measures that were collected directly from patients. But we recognised the limitations of it and we really needed to upgrade the data collection. to move the technology on. And last year we received funding from PPF to upgrade and build a new system. So this is where we're at the moment, and I'll show you what that system looks like and how it will work in private practice. So we're really excited about this. And the main benefits, it's a much more streamlined, user-friendly system that has automated proms and prems, and it will enable and underpin the quality framework that we will introduce in the coming months. Okay, so just an overview. You'll see from what Roanna talked about is how the data collection, the two different surveys. So we have a baseline patient survey that's collected before their first appointment, a follow-up patient survey that's collected 3 months after their first appointment. In private practice, we also have a clinician survey, really short, about 4 or 5 data points, and a 6-monthly organisational survey, and that provides the context and understanding about where the treatment is being provided. Within the data collection, we also include our case mix adjustment factors, so we can adjust when we look at quality and benchmarking, we can adjust for the severity of patients that are entering for treatment in that service, and we understand the demographics, so we can really understand those health inequalities and access. We're looking at, within the private data collection, we're also looking at treatment data and what treatment was provided. And then we've got various different quality indicators that are all validated. So on the left, you can see an overview of the infographic. So this provides kind of an insight into how it all works. And what's really important, it's really simple and easy to administer. So the data for patient enrolment is automatically entered, either by PMS or by the clinician via the website. Patients receive surveys via text messages and emails, so the clinician doesn't have to manually send these out, and they also receive the clinician follow-up survey. And through the system, their data provides, the data is used for insight, analysis and benchmarking. So I'll take you on to, so first of all, I'll show you quickly, Roanna signposted you to the data dictionary for the MSK National Audit. You're also able to access the data dictionary for the data for impact. And just to say, these are completely aligned with just a couple of extra data points for private practice, just to understand the treatment provision and the reasons for accessing private rather than NHS. And it's really important that these data collections are aligned to enable us to create this much larger national data set, so we can link up and understand access between private and NHS services. So I'm going to take you now to the Data for Impact platform that we've built. And I think it's a really easy to use platform, but I think the main thing to really stress here is that because we want to collect data from routine data collection. So we know that particularly in private practice, there's varying degrees of kind of technology use. Some people are using paper notes, some people are using practice management systems, and some people are using PMS systems with kind of integrated like speech technology such as Heidi. So what we want to be able to do is link to and enable every clinician to collect data and enter into the national data collection. So this platform allows this. So what we've created, and the technology company that we've been working with has built an API that links this data collection platform to PMS companies. So the patient enrolment can happen automatically through the PMS, and the data for the patient that's attending and their contact details is sent from the PMS to our data platform, which then pushes out the patient survey for pre-treatment and then 3-month post. And that's really important, because the way in which we collect, and we've learned over the last 10-12 years of collecting data, the way in which we kind of facilitate the data collection is really important to enable a patient data from every single patient and from every single clinic. So that's being launched next week. The other thing that I want to point you towards is where this reporting and benchmarking, and this is what we're working on. So I'm going to flick to the next stage. This part isn't ready for the Data for Impact platform yet, but we're going to work on it once we have the data available. So this is a slide, and this is just looking at what Jonathan presented earlier. It's the dashboard, the MyDashGP dashboard. And this is what we'll be creating for private practice as well. So a dashboard that will communicate and be interactive for practitioners, so they can see the data that they're collecting and they can compare their clinic to other clinics and understand their trends over time. So yeah, so that is in the coming months once we have the data available. Okay, so I'm going to move now towards the quality indicators. And as you will have seen from Jonathan's presentation, the dashboard hosts the quality indicators, and these are the indicators that will be defined and used to look at and understand how that practice or clinic is changing over time. So what we need to establish is what those indicators are. And at the moment, we know that there is a need for robust quality indicators in MSK care, and this is recognised nationally and internationally. And this is because we know services are highly variable, and studies show that there's up to a 15-fold difference in resource use. There's a 30-fold variation in imaging rates, and there's wide variations in waiting times across the NHS services. So without an agreed set of indicators, then benchmarking and quality improvement between services and trusts and between clinics in private practice is inconsistent. So there's no consensus yet to what indicators matter most. So this is what we're building upon. So this is our aim to, and this is where we're starting with how to develop a quality framework. So what we want to do is develop a prioritised evidence-based set of quality indicators that can be used for community and the private sector. And the most important thing to kind of emphasise here, it's not just a set of indicators that are theoretical. We want to be able to map these onto meaningful data collection points that are feasible to collect through everyday routine data collection. And then from these quality indicators, we'll build a national framework for quality, and this will feed into the learning health system that we've talked about. So I'm going to move to this slide here that will kind of provide you an overview of the development of the quality framework, and I'm just going to talk you through this so you can understand where we are with this. So the first stage of our work was a systematic review to identify and understand all the different quality indicators that have been identified and are currently being used nationally and internationally. So this was our first paper that was published this year, and in this study there were over 400 indicators that were identified, and these were we made sense of these by synthesizing these into 11 overriding quality themes. So this kind of gave an understanding into what was currently being measured and used to indicate quality. Stage 2, we looked at prioritizing all these indicators and making sense of them. So this was a Delphi consensus process, and this included clinicians and patients. And from this, the 400 indicators were reduced into a set of 59 indicators that were grouped into 6 different themes. So that gave us kind of a working list of what kind of quality indicators were deemed relevant and clinically important to patients and clinicians. And this is our most recent stage. So stage 3 was the mapping of these quality indicators that were evidence informed to our data dictionary. So this was to identify and bridging the gap between what were clinically meaningful and how we could feasibly collect these data points. And this is where we're at. So I'm going to turn and show you.
2 minutes left, Charmaine, and then we're going to take questions.
I'm going to quickly speak through this. So this is a work in progress, and I'll show you the next stages. But these are our themes here, and we have 17 quality indicators. And our next slide will just give you an overview of the theme, the quality indicator, and then on the right, the measurement type. So and where we're going to use the data from our data collection to collect on the quality indicator. And just to emphasise, so this is being taken to the next stage, which is here, where we collect the stakeholder input. So this will be used, we'll take these to stakeholders and clinicians and patients to ensure and get some feedback to ensure the practicality and the relevance of these reduced set of indicators. And then from that, we're going to take it to a final framework where we look at how the cut points and the benchmarking methods for the overall framework. I'm just going to point you to the websites there, because we're going to provide updates and invitations on how to get involved and report on each of the updates and obviously the final framework that we hope will be in place by the end of this year. Okay, so just kind of wrapping up, I just want to say the wider impact on why this is all important, and just to say that by developing a national set of agreed quality indicators, we're creating a consistent and evidence-based approach to understanding and improving quality of care across the UK, and that the DFI platform that we're launching next week will enable the private physios to contribute to this, and it will be feeding into a national MSK data set that will allow them to benchmark their performance, identify areas of improvement, and track patient outcomes over time. And just really importantly, that the creation of a national data set helps create a unified voice for MSK physiotherapists, and it builds a picture of quality and impact across the NHS that is evidence and informed by real world data. So just going to point you here to our two websites so you can get further information, and there's contact details there and some information about the community of practice that is next week. And that is it. Hopefully I'm on time, just about.
Yeah, brilliant. Thank you, Shemaine.
Thank you.
So now's the time for us to take some questions. If you want to put some questions in the Q&A, or that would be fantastic. I know that we wanted to leave a bit of time because we've presented a lot of information, and there will be questions, I'm sure. So I'll give you a minute, but hopefully I'll see some posts coming any second. But thanks, Shemaine, and thanks, Roanna. It's exciting to be part of such a big project, and we've got obviously big ambitions in terms of where we want to go with this, and lots to do as the data starts to come in now, in turning that data into that health intelligence piece. And as Roanna says, the quality will be the first focus, but there's also lots more that we want to do. And one thing just to point out is that we are allowing access to the database to non-Keele people. So I think there are 9 master's students this term who are using the data. There were 10 last term. If there are other universities and master's students or PhD students who want to access that data, do get in touch. We've got a formal process of people requesting to access data, which is exciting. So first question, so from Alistair, he says, fantastic initiative. What's the follow-up rate for the PROMs at 3 months, and why did we set at 3 months? So I'll ask Roanna to answer that one. Ro, would you answer that one for Alistair?
Yes, so it's varied, I think is probably the answer to that. I think we've had, in our first wave of data in terms of follow-up, we've had some services that have got 2% of patients that have got follow-up data, up to another service that's got 30% of patients with good quality follow-up. So it is at the moment inconsistent, and that is exactly why at the moment for that first 6 months of data, we're going to work with our providers to ensure that we can bring up that percentage rates, that we have high quality of data across all of those services. But yeah, it's a really good question. I think it's a key problem, and I think it's why initially it's great for us to have a look at all the baseline data and, as I say, work collectively as that community to drive up the quality of the data that we're looking at.
Great. A question from Claire. Will you consider input from indirect stakeholders. For example, if I'm a manufacturer of MSK Rehab technology, what information could I use from this database or dashboard? Who wants to answer that? Ro, again to you, possibly?
Say that again, I was reading.
That's all right. So this is what about industry? Are they going to be given access to the data? So at the moment we've not said yes to industry getting it. I think that's just because we're not. I mean, it's one of those things I guess we've got to talk about as a team. But at the moment, what we've agreed is that we'd let this be open to researchers. And I think it's perhaps because of trust and where we've got our ethics approval. But at the moment we've not allowed that, and we would have to change a number of things. It would have to be clear to patients if we were going to make it available to industry, and that's certainly not what we're saying at the moment in our data privacy statements and in our consent. But yeah, I should think we'll get more of those questions, but thank you, Claire, for asking that. But at the moment, the answer's no. Vincent asked a question. Thank you for all your interesting presentations. Congratulations on the work. Is there any opportunity to collect data on multimorbidity as well? Anyone want to answer that? I mean, I can answer that we are certainly in the GP data, we get all the multimorbidity data where that's available to us from the electronic health record. We are asking about comorbidities in our survey, but and there is some detail on that, and we are able to kind of sum the individual comorbidities to sort of define those with multimorbidity. But I think that will be something that gets better and easier, particularly for the NHS data when we've got the electronic health record piece coming in. At the moment, it's just the survey. So we're just limited to that one question that asks about comorbidity. Let me go up to another question and post by Adrian. Looks very exciting. Thank you. Very interesting. How is the quality of life well-being being measured? Have you considered ONS well-being measures? Which single item measure for physical activity is used? So I can answer that. So we're using the MSK HQ, Musculoskeletal Health Questionnaire, as the measure of overall, MSK status. But in terms of well-being specifically, there's only a couple of questions in the MSK HQ, which there's one on sleep, one on emotional well-being in the MSK HQ. And in terms of physical activity, we're using question 15 from the MSK HQ, which asks about in how many days in the past week have you done moderate 30 minutes or more of moderate exercise. So that's the question that we're using for that. Have we considered the ONS wellbeing measures? No, we haven't. Happy to go and have a look at that. What we do find is that lots of different people would love us to ask additional questions, and we've just had to be really, really strict. If we're going to get good follow-up rates, we need to really be very focused on which items we absolutely need for our quality indicators. So we have some measures of well-being, as I've said, but yeah, this isn't research data. It's trying to capture that routine data. But good question. A copy from the chat. Thanks, Alex, for putting this in. A question from Sue. Will the presentations be shared? We're very happy. I think this has been recorded, and we're happy for this recording to be shared. So yeah, I think the answer is yes. Some of the data that we've shown, we've not published yet, and we do want to. So I think we've got to be a little bit careful about which slides we share. But it's absolutely our aim is to make everything that we're doing publicly available and freely available. So very happy. So if there's anything specific that you want, do reach out. Okay, a couple of minutes left. Are there any other final questions for us? If not, then let me say a big thank you to Ro and Shemaine for their presentations and for doing it all within an hour, which is great. So for once, we're on time as a team, but it is gone past 1 o'clock. So I suggest we wrap up there. And Alex, thank you for organising again. That's been a real privilege for us to present today. So I'll finish there. Thank you, everybody.